was very young when I first tested HIV positive at antenatal. I did not understand the danger it meant.
Chikondi tested HIV positive during her first pregnancy. She was 18 and terrified. Unable to tell her husband, she built her family without starting HIV treatment.
I had 5 children without treatment. My eldest daughter is HIV positive.
Chikondi's story highlights the challenges faced by programs to prevent mother-to-child transmission of HIV. Treatment was available, but Chikondi did not feel she could take it. So what can be done to retain women like her in care? Most African countries have rolled out Treat All, previously known as Option B+, where all pregnant women who test HIV positive are started on lifelong treatment. The medicines not only keep the mother healthy, they also dramatically reduce infectivity, making her very unlikely to pass the virus to her baby, as long as she stays on treatment through pregnancy, birth, and breastfeeding. But a significant proportion of women drop out of care for a variety of reasons.
If a woman is not coming back, then you don't know whether they are swallowing the pills. And if they are not taking the pills, then they are not going to have viral suppression. So they are more likely to transmit the virus to the infants.
A woman goes to her first antenatal visit to have the health of her baby checked, not to have an HIV test. So her reaction is often, "No, I cannot take the ARVs. I'm not ready. I must speak to my husband first."
In terms of dropping out, young women, teenage mothers were particularly at risk. Women that came to book very late in the 3rd trimester, and then women that are finding out their HIV status for the first time during that first antenatal visit.
I cried when I tested positive at antenatal. I went out of the clinic and I started shouting at my husband. I could not believe it. It took several months before I could accept the results.
The main reasons my clients drop out of treatment, it was fearing of getting divorced.
We had some mothers who were told not to take their ARVs by the prophet of their church.
One was like, I have to be taking medication each and every day of my life. So it was like a burden to her.
I think women face issues in PMTCT when it comes to receiving services from the health personnel. If you work in the health setting, you discover that some health personnel, some health providers, they act to these women the way the women feel very bad.
The search for better retention of HIV-positive mothers started with 2 studies to improve health centers. Too long lines, stressed staff, and poor services put women off. A study in northern Nigeria used a method called continuous quality improvement. Health workers were trained to identify, implement, and evaluate initiatives to improve their facilities. Bottom-up change, the idea goes, will be more effective at improving patient satisfaction.
When clients are satisfied, we know that they would not just come back to the facility, thereby enhancing retention, but they also become advocates for others to really come in and utilize the services.
This was a cluster randomized trial carried out in 32 facilities. The results showed that it changed the atmosphere in health centers, dramatically cut waiting times, and boosted the skills, morale, and motivation of healthcare workers.
Before, we are tired, everybody said the clients are angry, we are angry, there's always one or two complaints. But now, as you can see, we had a very, very cool environment. We work at ease, there is no problem.
But the changes did not translate into improvements in retention. Possibly the study needed to have continued for longer for the impact to be felt at a community level. Or perhaps most women who stop treatment do so because of reasons that health centers cannot resolve. The results were mirrored in the PRIME study in Malawi, which also sought to improve health center care. With separate visits for vaccinations, family planning, ART, early infant diagnosis, mothers lose many days at the health center. Would it help to integrate services for HIV-positive mothers and their infants, combining all these visits into one weekly clinic?
The idea is that the less visits that the mother has to come, the more likely that that mother will come for that one visit, that she would get everything.
As a parallel intervention, the study also tested an SMS reminder service. If mothers miss an appointment, healthcare workers will SMS a community volunteer, chosen from the village health committee, to go to the mother's house to remind her. While popular with some mothers, neither the SMS service nor the integrated clinics improved retention rates. The project struggled to motivate overstretched healthcare workers, and often the SMS messages were never actually sent.
The biggest lesson in this study was that even simple interventions require a strong health system. If you don't have enough human resources, if you don't have enough space, that's going to limit the level to which you can implement those integrated services.
Intriguingly, when reminder messages did arrive, the data showed that mothers usually responded and went to the health center. It suggests a more reliable communication link between health center and community might be effective. Two other health center-based interventions were carried out in Zimbabwe, which add more pieces to the puzzle. Do mothers starting treatment the day they test positive really understand why they are taking medicines? Would better knowledge improve retention? This project used enhanced counseling around CD4 testing to educate about HIV and the immune system. Participants did end up knowing much more and were more likely to turn up to CD4 tests. But this did not translate into better retention.
What we identified is that there are complex factors related to family and also community that need to be looked at in such interventions, and our study did not address some of that.
The second study in Zimbabwe looked at peer support groups based in rural health centers. Mothers help each other to learn about HIV and live positively. The groups met at least 8 times. Each session explored a different aspect of living with HIV, using peer-led education, role plays, song and dance. The groups were very popular with participants and showed an improvement in retention. But the result was not statistically significant, and some of the most vulnerable women did not take part. Staff said it was almost always for the same reason.
Disclose the barriers.
Women who had not told their status to their husbands found it very difficult to attend the weekly sessions. It is very difficult to go to the support group if you have not told your husband and your relatives. The day you are going, everyone wants to know what you're going to do. The topic of disclosing to partners was the 5th out of 8 teaching sessions given to the support groups. Some participants suggested that it should have been the first, and that men should have been invited to take part. The final INSPIRE studies, one in Malawi, the other in Nigeria, evaluated the use of peer support by well-trained and supervised HIV-positive mothers.
When this third test came out negative, I jumped. And when I looked at him, I was like, my son, you are free from the virus now, you're okay. I was very happy, and up to now, when I look at him, I'm always very happy.
The strength and commitment of women like Patricia, who gives peer support in Malawi, is built on their own stories as HIV-positive mothers. Her first babies, born 7 years ago, were twins.
Being a boy and a girl, I was like, wow, thank you. This is where I'm going to stop. It was like, I have a boy, I have a girl, that's all, yeah. But then I didn't know my HIV status.
The twins died when they were 4 months old, one on Saturday, the other on Sunday. Soon after, Patricia herself became sick and tested HIV positive.
It was a very, very painful moment, because if I had that courage to go to the hospital and know my HIV status first before I got pregnant, the chances for me to transmit the virus to the babies could have not been there. So I was like, I was selfish.
Patricia worked through her pain and went on to have a baby boy. Today, a healthy 5-year-old who is HIV-free. Then, 3 years ago, she saw a notice in her health center looking to recruit peer supporters as part of a large clinical trial.
They want these women to help their fellow women, to educate them, to counsel them, to move with them, to encourage them. So I was like, I can do this. I don't want to have my fellow women go through the pain that I did. I just want to help them.
In the PURE study, 21 rural health centers were randomized into 3 groups. 7 sites recruited mentor mothers, 7 recruited expert mothers, and the last 7 sites had the standard peer support of the national program. As an expert mother, Patricia will be on hand at antenatal sessions to accompany women who tested positive, counseling them intensively until she was sure they understood the diagnosis. She will follow up with home visits to remind about appointments and help overcome obstacles. It was her that helped Chikondi to finally go on to treatment after years of living a double life.
We do share experiences. I've gone through this, and I overcome it in this way.
After Patricia helped her start ART, Chikondi had 3 more children, all negative.
I was pregnant again when I met Patricia. She persuaded me to go on to treatment. If I had not met Patricia, then my other children could also be infected.
The PURE study results showed that the work of expert and mentor mothers like Patricia leads to a significant improvement in both the uptake and retention of women on PMTCT.
The way we designed the study, it was quite rigorous, whereby we defined what the mentor mothers at the facilities should be doing, the expert mothers in the communities, what they will be doing, and the supervision was quite significant. So I am confident that we can reproduce the results from the study.
The PURE results were backed up by a similar study in Nigeria. The Moment study compared the use of paid, well-trained, supervised and supported mentor mothers with a standard mentor mother program.
The reason why we went into engaging mentor mothers as our study intervention was really because of our confidence that mentor mothers could do this job, but also of our realization that it needed a bit more structure in order for us to get maximal or optimal outcomes from peer counseling.
The results were very clear. Closely supervising and supporting mentor mothers made a big difference to their effectiveness.
When the mentor mothers go out into the field and come back to the healthcare facility, they have someone they can go back to and say, this is what I encountered, or these are the difficulties I'm having. How can you help me fix these problems? How can you help me understand better?
The supervisor of these mentor mothers really helped. She makes sure that all these activities that is supposed to be done is well done to, at the end, have a negative child.
Women supported by well-supervised mentor mothers were also much more likely to bring their babies to be tested for HIV.
What we need to do is actually provide a structure and supportive supervision to motivate mentor mothers to do their work.
This one is negative client.
This is good evidence from large trials. But researchers say the mentor-expert-mother intervention is multifaceted. The mothers counseled, provided peer support, organized support groups, did defaulted tracing, home visits and family counseling, and the close supervision led to some health center improvement.
Although we have shown with our results that peer support is beneficial in retaining mothers, we don't really know which aspects of the different interventions were most effective. Whether it was the one-to-one contact that mothers had, or it was the home visits or the support groups. So this is the next step. We now need to find out which is the most efficient way.
This fits closely with the evidence given by mothers in social science research. Mothers consistently cited fear of divorce as the most common reason for women dropping out of treatment.
Mostly, the women lacked partner support. So for the sake of preserving their marriages, these women stopped accessing treatment. For some of them, their drugs were thrown away in the toilet. For the others, their spouses said, you don't need to go to the facility to get the medication or else you'll be divorced.
Mentor mothers also reported that the huge benefits of early HIV treatment are still poorly understood in the communities they serve. Patricia found people often did not believe she is HIV positive because she doesn't look sick. And hardly anyone knew that successful treatment massively reduces infectivity, even though this is the central tenet of PMTCT and test and treat. She found once husbands understood the benefit of ART, they were much more willing to accompany their wives for testing.
When my wife got tested, I was very disappointed. Our marriage nearly broke up, but I took advice from Patricia. The trouble in Malawi is that men think they are superior. If a wife tests HIV positive, then it is the wife's fault. To change this, we need men to talk to men.
In Patricia's district, they managed to get 90% of husbands tested because village chiefs made it mandatory for men to go to antenatal sessions. But this was the exception. More typically, in this health center in southern Malawi, expert mothers only got the husbands of 11 of the 44 women they enrolled to be tested. So to bring in reinforcements, organizations implementing the study are now hiring HIV-positive men to work alongside the mothers. Meet the male motivators, another idea for improving retention.